Okay, thank you for coming here today. Would you tell us briefly about the PROTECT-AFib trial and what is the important message of this trial?
Sure, it's a great question. It's great to be here. I think that one of the issues that we face with increasing frequency are those patients that have atrial fibrillation. We know that atrial fibrillation increases as a person gets older, number one. Number two, the incidence of stroke related to atrial fibrillation also increases as a patient gets older. So we are faced then with an increasing large number of patients who are at risk for that increasingly most dreaded complication of stroke. In the past, there has been concern in patients with atrial fibrillation, or there has been controversy about what causes stroke in those patients. And to a large extent, I think that has now been identified and addressed. Information in the past has said that 90% of all strokes that arise from atrial fibrillation come from the left atrial appendage, from thrombus in the left atrial appendage. So several years ago, the thought was perhaps you should exclude the left atrial appendage from the circulation. If you could exclude the left atrial appendage from the circulation, then you would avoid, number one, the potential for thromboembolic strokes from that location, and number two, you would avoid the need for anticoagulant therapy. Both of those would be important goals. And so the PROTECT-AF trial started out with the hypothesis now several years that said we think that stroke comes from the left atrial appendage in those patients with valvular atrial fibrillation, number one. Number two, that by in some way stopping flow out of the left atrial appendage, like a cap or some other means, that would work to prevent stroke. And indeed, the PROTECT-AF trial documented that. It's been of interest that the PROTECT-AF trial was published now in 2009, some time ago. At that point in time, from the regulatory standpoint in the United States, the United States said we needed to have more data, even though the data showed that it was about the same as was Coumadin therapy, as was warfarin therapy. Since that time, we now have 5-year data. And the 5-year data would suggest that in contrast to warfarin therapy, the placement of a device decreases the primary endpoint, which was a composite of all death, systemic thromboembolism, and other problems, and stroke related to that, decreases that by about almost 25%, increases stroke by about 25%, increases cardiac or all death by about 25%. So it indeed addresses the issue that thrombus comes from the left atrial appendage and is better than warfarin therapy. Final piece of information is to say there was an early safety hazard with the device. If you take a patient that has atrial fibrillation and you want to occlude the left atrial appendage rather than give them warfarin therapy, a prescription, the risks are going to be a little bit different because there are the procedural risks up front, and those were identified. The most common risk was a pericardial effusion, and that then was seen in about 5% of people. Didn't cause any fatal outcome, but certainly was a dramatic incident when it occurred. Since that time, there have been what have been called a continued access registry, and that has shown that the pericardial effusion rate is about 2%. So I think in summary, the PROTECT-AF trial, number one, documents that indeed the hypothesis is true in patients with atrial fibrillation. Stroke comes from the left atrial appendage with thrombus there. Number two, you can include the left atrial appendage safely, or relatively safely. Number three, it gives you just as good results as if you were going to put the patient on long-term anticoagulant therapy, and oftentimes even better results than that. That's really the PROTECT-AF trial in a nutshell.
We know the PROTECT, Watchman, I'm sorry, 다시 할게요.
네, 목소리 좀 조금 크게 나왔어요. 너무 잘 보입니다.
They want to hear sounds more loud, bigger. Yes.
Okay.
The record. I'm sorry.
자.
As you mentioned today, the Watchman device implantation is safe procedure. But we want to know about the complication related with the procedure. Please tell us how fatal the procedure-related complication during the Watchman device's implantation.
Sure, it's a great question. There have been a couple of different pieces of information about that. Number one was the PROTECT-AF trial that randomized patients to either warfarin therapy or the left atrial appendage Watchman device. And the other piece of information is a continued access protocol where, following the initial randomized trial, patients could be given the device as part of a long-term registry. There are a couple of important safety pieces of information. The most common safety piece of information with the Watchman device is pericardial effusion. Occurred in the Watchman trial about 5%. There was clearly a learning curve. If you hadn't done very many cases, you had a higher incidence of complication. In the continued access protocol, that rate of pericardial effusion is about 2%. It did not lead to any mortality. Some of the time it could be treated with just pericardiocentesis. Some of the time, less often, it required cardiac surgery. As we have gotten better in terms of experience, and as the technology has gotten better and the approach has gotten better, that incidence has decreased. But again, the incidence of fatality related to pericardial effusion was 0. The second piece of information in terms of bad safety events were procedural-related strokes.
Mm-hmm.
We take a patient in whom we're going to put in a device to prevent strokes, and during that procedure, you can cause a stroke. That was seen and addressed in the Watchman trial because it looked like it was the result of air embolization. We have had information on that in terms of large catheters being used in the pediatric literature as well as in the adult literature, where they do what is called trap air, where air is sort of trapped along when the large catheters are placed into the central circulation. And the cases of stroke related to the procedure were related to air embolization. Since that time, as we've learned about that, as we've learned to manage air embolization in the setting of the Watchman device, the stroke rate is now 0. The third piece of information relates to bleeding hazards. That is an increasingly important part of interventional cardiology because these catheters are placed from the femoral vein with also femoral arterial monitoring and measuring of arterial pressure. You can have peripheral vascular complications with bleeding. Because these are venous access things, that has been less of a problem. It is still a concern in these older patients in whom we're putting in the devices. So overall, since the trial was initiated, since PROTECT-AF was initiated, on into now the continued access registry, the procedure has become safer and safer and safer as physicians have become more experienced, as the technology gets better, as patient selection become improved.
Thank you for your good information. And then next question is about multivessel disease. The result of recent clinical studies for multivessel disease are a little bit discouraging to interventional cardiologists. Do you think we have to change our mind in selecting the treatment options?
It's a great question. Interventional cardiology has been an interesting field in that we started out with very straightforward lesions in very good risk cases. Those were the earliest cases that were done. Then as our experience and as the technology got better, we took more and more and more complex cases. And we then reached a point where indeed we were doing more procedures in the catheterization laboratory with PCI than the surgeons were doing surgical revascularization procedures. To a certain extent they are complementary procedures, but we weren't sure how complementary they were. There were a number of studies that said that those patients with multi-vessel disease might do better with surgery than with PCI, particularly if the disease was very complex. And that led then to the development of, at that point in time, the largest randomized trial, which was the SYNTAX trial. There were a couple of things that the SYNTAX trial looked at. Number one, they looked at patients with very severe extensive multi-vessel disease and left main coronary artery disease, and then randomized those patients to either surgery or PCI with a first-generation drug-eluting stent. The 4-year results were just presented this last year. They identified the fact that, indeed, depending upon the lesion complexity, that PCI was either a really good option or not so good of an option. In those patients that have extensive coronary artery disease but relatively focal coronary artery disease, so what has been called a low syntax score, that means that's an assessment of complexity, PCI looks very good. In those patients that have very severe complex disease, PCI hasn't looked nearly as good, and indeed there has been a survival advantage in that smallish select group of patients with coronary bypass graft surgery. And that has led the investigators and some of the field and some of the guidelines to say that as the disease becomes very complex, very severe, surgery looks better and better in terms of actually a mortality advantage. There were a couple of issues with that. The first relates to the fact that the technology that was used in syntax was a first-generation drug-eluting stent. As we use better and better drug-eluting stents, that answer may change. The second piece of information is that there is increasing interest in what are called hybrid procedures. Hybrid procedures are a combination of surgery and PCI. There are now centers that do quite a few of those procedures where a left internal mammary is placed to the LAD for survival advantage, and then the other vessels, the circumflex and the right coronary artery, are treated with drug-eluting stents. That has the advantage that you can use a very minimally invasive surgical procedure, number one. Number two, it avoids the placement of saphenous vein bypass grafts, which do not last. Still, as we put it all together, while the technology continues to evolve, while you have better and better drug-eluting stents, surgical techniques are also getting better. We become more and more adept at selecting the right patients. In those patients that have severe extensive disease, the information would suggest that the old strategy that we used to say was the case, that coronary bypass graft surgery has a survival advantage, is still the case. And so I think that while there are answers to questions that still we need to address, such as the hybrid procedures, such as the placement of new drug-eluting stents, I think that what this is to say that the surgeons and the interventional cardiologists need to work together to identify those patients that will specifically benefit from one revascularization procedure versus the other. And so that then solidifies the importance of the heart team concept, where each individual patient is being given specific recommendations for that individual patient by the team of interventional cardiology and cardiovascular surgery.
Thank you for a comprehensive answer today.